So it's starting here.
Good afternoon, depending on where in the country you are coming from, and welcome to our webinar today. My name is Alan Bell. I'm a family doctor in Toronto and co-chair of the Implementation and Education Committee of Hypertension Canada. Thank you all very much for joining us today for Hypertension Canada's webinar on how to manage hypertension in a pandemic. It's hard enough to manage hypertension without a pandemic, but we're very fortunate today to have Dr. Ann Thompson speaking to us and doing this presentation following this short introduction. Just a few housekeeping notes. In order to reduce all the background noise from the large number of participants that we have today, it will be necessary to keep you muted throughout the presentation. However, I really want to emphasize how much it enriches the presentation if you use the Q&A function. There's a button at the bottom of your screen to submit questions that we will be addressing at the end of the presentation. So please submit your questions and enrich our discussion. A recording of this webinar and the slides for download will be available on the Hypertension Canada website at, as you might have guessed, www.hypertension.ca. Please visit the site, download the slides, review it for yourself, share it with your friends. Copies, following this presentation, you will be receiving an evaluation by email. Please help us to continue producing quality education by completing your webinar. Tell us where we went right, tell us where we went wrong. So in terms of disclosures, these are my disclosures. I'll give you a moment to review them. Probably most relevant to this discussion is, as I have already disclosed, I'm the co-chair of the Implementation and Education Committee for Hypertension Canada and am on the board of directors. Neither of the speakers are receiving any honoraria from the presentation today. These are Dr. Thompson's disclosures. They take much less time to read. One further disclosure is that this program has received financial support from A&D Medical, LifeSource. I wish to emphasize, however, that the presentation has been solely created by the speakers. There has been no commercial organization from A&D Medical or any other organization that has had any input to what you are going to see today or has been privy to any of the content prior to today's presentation. We're going to start with a poll. We want to know who you are. So which category do you belong to? Are you a doctor? Are you a pharmacist? Are you a nurse? Are you a patient? Or are you something else? You can submit your answers now. Please vote. Okay, thanks. So it looks like we've got about 69%, about 70% of you, healthcare professionals, 3% patients. Welcome to all the patients of this webinar. Thanks for joining us. And 28% of you are others. Okay. All right. Let me close this thing. We have a second polling question. We want to know where you are. Are you in which of the following provinces? I think you can go ahead and vote. Well, it's very nice to see that we've got representation from across the entire country, the majority from Ontario, but a nice group from BC, Alberta, and it's also nice to see the Easterners also joining our presentation today. So thank you all for coming. You know, we're living in a world today where we are seeing just massive improvements in cardiovascular prevention, both primary prevention and secondary prevention. Exciting news is continuing to come out of the diabetes world. We're seeing amazing antithrombotic, anticoagulant, antiplatelet agents evolving. The lipid world is exploding with PCSK9 inhibitors, fish oils. We're inundated with options to reduce the cardiovascular risk that our patients are facing. But it is just so easy to forget about blood pressure, good old blood pressure. I think we have to remember, as has been nicely illustrated by Alex Leung in his publication last year, that high blood pressure remains the leading preventable risk factor for disability and death from cardiovascular disease in the world. And that is particularly true in the Western world and in Canada. So let's not forget about good old hypertension when we're considering the cardiovascular risk that our patients are facing, both primary and secondary risk. You know, there is absolutely incontrovertible evidence of just how powerful the effect that we can have on lowering blood pressure is on the impact on cardiovascular disease. Consider some of these numbers. In 2015, hypertension was directly responsible for approximately 10.7 million deaths. You know, putting that in perspective, the current pandemic that we are facing, and one of the reasons for this webinar today, is less than 1/4 of that number over 1 year. And that was in 2015, and that number is steadily growing. Not only are people dying, people are becoming disabled, and hypertension is responsible for approximately 211 million disability-adjusted life years lost back in 2015. In terms of financial costs, about 14 billion in 2010, a number that has doubled over that next decade up until 2020. So some $27 billion. Hypertension is why patients come into primary care offices. The second most common reason, second only to the common cold. And about 1/4 of Canadian adults suffer from this disease. So I think that it's critically important that we continue to emphasize management, awareness, and treatment of hypertension. And sadly, we're losing control. We've had so much to be proud of in Canada for so long because Hypertension Canada has boasted the best national rates for hypertension control of any country in the world. So as Canadians, we really should have been proud of that. But disturbing data are now emerging, showing that we're losing that control. We're losing control in detection of hypertension, treatment of hypertension, and control of hypertension. And that's in recent years. That is not just due to the pandemic. And we're seeing it throughout the Western world. Certainly we're seeing it in Canada. Certainly we're seeing it in the US. And it's very well documented. And it is not an equal distribution of who we're losing control in. The greatest impact that we are seeing is in women over the age of 50, mature women. Here are just some numbers to consider. If we take a look at the black line, these are the overall numbers of the control rate of hypertension in Canada. And you can see it's been fairly steady up until the last decade or so, when we have seen a steadily decline in control rates from rates of around 70% down to around 60%. But as I say, this has not been an equal distribution. If we take a look at the rates in women, we are falling now over the last decade to rates around 50% control, which is something that we really haven't seen in this country for many decades. This is something that is going to be critical to address, and that is nicely illustrated by the impact of what we've seen of cardiovascular events in terms of disability life years lost. We have seen a steady decline for many, many years on the rates of cardiovascular events. But what happened? Starting around 2012 or so, we have started to see these numbers reverse, and reverse in a very sharp and important way. Cardiovascular disease, probably the single most important cause of death and disability in the Western world, is rising sharply. And now we have a pandemic. So now we have to change the way we are treating hypertension. We have to change our approaches to medical care in general. And that's why we're very fortunate today to have Dr. Ann Thompson address this issue. So Dr. Thompson is a clinical associate professor and director of experiential education at the Faculty of Pharmacy and Pharmaceutical Sciences at the University of Alberta in Edmonton. For over a decade, Ann has practiced at the University of Alberta Hypertension Clinic. She is a prescribing pharmacist and works collaboratively with internists and nurses to provide care to patients with hypertension. She teaches hypertension and blood pressure measurement to students, residents, practicing pharmacists, and primary care network healthcare professionals. So we're very fortunate to have her here today. She's to share her knowledge and experience related to hypertension management. And I will stop sharing my screen, or have I already done that?
I've already done that. So my screen should be shared now. Thank you so much, Dr. Bell, for that lovely introduction. As he said, I have worked in a hypertension clinic for many, many years, since actually 2006. I moved to Alberta at that time from Nova Scotia. So really great to see lots of pharmacists in the audience today to learn a little bit more about hypertension. In my practice, we are a tertiary care referral center. So I'm going to be talking a little bit today about strategies for providing virtual hypertension care. And I'm really trying to contextualize that to the primary care audience, because I think this is, you are the people who are actually doing the heavy lifting with managing this condition, and how can we do it successfully when we can't see our patients face to face at all times. After describing my work in the clinic, we'll then move to describe how to select an appropriate home blood pressure device and check for accuracy and validity. And then finally want to review resources from Hypertension Canada for support and education of patients, as I think that's a critical role that we all play, but especially in primary care, and empowering you to empower your patients to do a good job of that is so important. So I just want to launch one more polling question to get your feedback on how often you would use the Hypertension Canada website. And there's a few options there for your selection. So. Just give you a few seconds to respond there. Okay, so we have quite a number of votes that have come in, and I'll share those results with you. So it looks like the majority of you haven't used the website at all, so you've come to the right webinar if you're looking to learn what Hypertension Canada can do to help you with your practice. But then nicely see that, you know, some of you use it quite frequently for both patient or professional information, and then sometimes to educate yourself. So that's great. Okay, so I'm going to talk a little bit about delivering hypertension care virtually, and just wanted to start off with a recent BC survey that was done with 56 general practitioners. And this was done to sort of get a sense last summer of what was happening as a result of the pandemic to in-person visits. And you can see they used the cut point of March 15th in 2020, and you can see that a minority of visits were by phone. But this dramatically increased by phone and video after March 15th. So up to, you know, 4/5 of your visits were being done in this regard. And they also reported that more than 80% reported serious reductions in the ability to get blood pressure measurements, either manual, automated, or pharmacy-based measurements. And largely that was due to the concerns around transmission of virus and using this equipment and keeping it clean and appropriate for use. So this led to a concordant increase in the amount of reliance on home blood pressures. And of course, the main concern with the use of home blood pressure is the validity and reliability of these measurements. And so there's also a concern around accessibility. So for patients who don't or can't afford a blood pressure monitor, cost may be a barrier. And so with that, we are getting less opportunity to get measurements. Additionally, because maybe in the past we would share or loan monitors from primary care practices, given that we didn't necessarily have staffing or cleaning protocols, this wasn't happening. And the same within pharmacies, letting the public self-select to use a blood pressure kiosk didn't seem to be prudent at the time. So we're hoping, of course, much of this will be alleviated once the vaccination is more fully in place, but certainly it's created a challenge for how can we help patients manage their own hypertension. So this slide just outlines a little bit about my workflow in the hypertension clinic that I work in. And I sort of have broken it into 3 phases: the pre-visit preparation phase, the virtual phase, which for my practice has mainly been phone instead of video, although video is an option. And then of course that post-visit collaboration and documentation and sort of wraparound pieces that happen as a result of seeing a patient. So just to start with the pre-visit preparation, this is really where I'm fortunate in my province to have access to an electronic health record or an electronic medical record. And those of you in provinces where you do have access to these tools, especially if it's in collaboration with other team members, that can be really, really helpful to get a sense of what has been happening with your individual patients. And for those who are pharmacists, you would also have probably some access to maybe some provincial EMR records, but you may also have your own records within your pharmacy that would help you to also get a sense of what's been happening with a particular patient. So I'll have a look at that just to have a sense of what their blood pressure control has been like, what has been the plan in place on the assumption that this is a follow-up patient versus a new patient, and try to gather some of that data. If I have access to blood pressure readings through telemonitoring, I will have a look at those as well so that I have a more current idea of what the patient's level of blood pressure control has been like. And then finally, would have a look at some of the lab values. So in Alberta, we have a provincial EMR called Netcare, so we can log in and see how they've been doing from the perspective of their various labs that may give us an indication about their level of target organ damage or any other relevant tests that would help us manage their drug therapy with antihypertensives. So the last piece would be those medication refill records. And of course, pharmacists would have this readily available in their practice. I can see those records as well through our Netcare integrated system. And that really gives me a sense of the likelihood that a patient may be taking their medication, but obviously is supplemented by my actual conversation with the patient about what's happening. So then we move to the virtual visit. Like I said, we've been mostly doing phone calls. There is within our EMR the ability to conduct a secure video visit. I haven't done those yet, but certainly I would say our patients have found it very satisfactory to be able to meet over the phone. It's very convenient for them. So this is where I will gather a focused history, where I will sort of verify any information that I've maybe collected in advance or resolve any discrepancies that I have. It'll also give me an opportunity to investigate a little bit more closely what they've been doing for their own behavior, lifestyle changes, and what medications they are actually taking. And I think from a pharmacist lens, I'm really sort of also focusing in on what other medications beyond their prescription medications that they may be taking. So over-the-counter products, herbal remedies, things that potentially could influence their blood pressure, a notable one being the NSAID class of medications. So things like ibuprofen or naproxen, some of the brand names there would be Aleve or Advil. So how are they using those medications and how might that have an implication on their blood pressure? Of course, we would want to then note any red flags. So are there reasons that we actually do need to have a physical exam, that this person should be seeing their physician? So do they report anything such as new onset chest pain? Do they have new shortness of breath on exertion that seems unexplained to their normal routine? Any symptoms that might be concordant with palpitations, things that might be a clue to one of the cardiovascular endpoints that we're actually trying to prevent with treating their hypertension, but that we think require a little bit more investigation, either diagnostically or through physical exam. So sort of looking for some of those red flags to then determine if we need to have them be seen in person versus that virtual environment, and then providing some reassurance that we have safe ways to bring patients into our primary care sites or into our clinic to examine them. Thereafter, we get into the post visit. So in my case, because I work collaboratively with physicians in my clinic, after I finished my conversation with a patient, I would end up contacting one of the physicians that I work with, and we would have a discussion about what my findings were, what my plan was, and what we wanted to do going forward. So was their blood pressure under good control, and can we leave everything as is? Or was there a slippage or a lack of control where we want to escalate therapy? Or are there in fact maybe some adverse effects or some, blood pressure lows where we actually want to de-escalate some of the therapy or de-prescribe a certain medication based on how the patient's actually doing? I've also had examples where when I phoned a patient, they actually don't have any blood pressure readings that are current, but they actually own a home blood pressure monitor. So we actually hang up, let them go do some blood pressure readings, and then we reconvene our call so that I have some recent data to base some of the decision making on. So going back to that post visit, I will collaborate with my team members. Typically, it's a fairly short collaboration meeting, so anywhere from sort of 2 minutes to 5 minutes, depending on the complexity of the patient. Document sort of what our plan is, and then usually the physician will phone in my case, the patient thereafter to confirm the plan or to provide any other opportunity for the patient to share any details that they would like to. And then there's sort of all those wrap-up pieces. So if we need to order any lab work in this post-pandemic world, we're actually communicating directly with labs about the time frame and the types of labs that we want ordered. If there are any prescriptions to be phoned in, I'm still doing that by phoning things in. I know with the e-prescribe it initiatives, there are ways to electronically prescribe through some of the health records. And then we're setting a date for follow-up so that we can review what our plan achieved and in that appropriate time frame and follow up at that time. One note I will make is that for our patients who have been stable on therapy, we certainly have been very cognizant of how often we're sending patients for lab work. And unless we feel it's critical, especially when the pandemic had numbers that were getting really high within our jurisdiction, we were trying to minimize lab visits to the extent possible. So just want to talk about that follow-up piece and what do we, how do we determine a follow-up schedule? And then what are we looking for in that follow-up? And this is an older slide from Hypertension Canada that sort of gives you the general rule of thumb. And I would say we follow this, that if you're not in control, we want to follow you up in about 4 weeks as a general rule of thumb. But if you have been in control for at least 2 visits, and we might even extend that if things have been seemingly under control for 1 visit for the period of time prior to that, that we will extend those intervals of follow-up to 3 or 6 months and maybe even a year if we've been following you consistently for a long time and have a good sense of how your hypertension has been managed. The one caveat to that would be if we have patients who have extremely high blood pressures where we're quite concerned about their ability to tolerate and continue with the medication regimen that we prescribe, and we may follow them up at a shorter interval to just ensure that we're getting some lowering of the blood pressure and that we're seeing the tolerability of the medication, so that if we have to make some shifts, we have the opportunity to do that. We also want to look at notable events. So since we last saw you, did anything happen that you felt was, really impacted your health? And specifically thinking about any hypertensive urgencies that may have happened or really high blood pressure readings. Did you ever feel, or did you ever go to the emergency department because you were concerned about your blood pressure? So we would want to note those types of events. And then we're really looking at, how the regimen is working. Are you feeling that you're not having any side effects? So does it appear to be a safe regimen? And are you able to remember to take your medications? In terms of the antihypertensives, we see that these medications typically take their full effect after 3 to 4 weeks. So the other reason why we give that sort of 4-week window is that we really want to see the impact that a blood pressure lowering medication has, so that we don't over-treat or up-titrate because we just haven't given the original plan enough time to actually achieve its full level of control. So that's sort of the rationale for that 4-week mark being particularly the sweet spot of what we try to arrange for in our practice. And I think, would lend itself to some of the primary care environments as well, given that, if you're in a pharmacy environment where there may be refills being processed, or even in a primary care setting where sort of on a monthly basis, you can have patients checking in on follow-up, but then extending those intervals if you're actually achieving the targets that you want to achieve. In terms of adherence, I just want to talk a little bit about that, and the pharmacists in the audience, I think, would really appreciate this, but such a role for pharmacists. I talk to lots of patients where they are potentially on regimens where there is a combination available and no one has necessarily thought to tell them about this combination product. And it may be that initially individual agents were being titrated up to their target doses, but it's really, really helpful for patients, and they are so grateful when there's an ability to combine medication and make their medication taking regimen simpler. I tend to spend a lot of time asking how and when they take their medications, because sometimes they're taking them at lots of different times of the day that make it quite complicated, and there may be reasons that we can streamline that for them. Cost options sometimes fall into play where they're having difficulty affording their medications. So are there some generic options or other suitable combination options that would actually keep the cost factor in play really well, which is nice to let them know about. And then of course, if adherence is an issue, lots of adherence options, from blister packing to dosettes and pill packaging solutions that can really help to just make it easier for patients to adhere to their medication regimen. And given that's such a backbone, I guess, of treating a chronic disease like hypertension, the more we can make this easy and simple for patients, I think we've seen some success in that regard. Okay, so I talked a little bit or hinted about eHealth Interventions and mentioned that we're using some telemonitoring within our tertiary care clinic. This has been a recommendation that has come out of Hypertension Canada in the 2020 guidelines, that the use of eHealth interventions may be a means to improve the management of hypertension, therefore reducing the risk of cardiovascular disease and improving health and well-being. And we have now been utilizing a home blood pressure telemonitoring platform that has been extremely helpful prior to the pandemic, but I would say during the pandemic has created some ease of gathering data that's been immensely helpful in our practice. So what I mean by a home BP telemonitoring platform is that it links a patient's home blood pressure data through a smartphone app to a cloud-based clinician portal. And obviously that takes a little bit of setup, but this allows the user to input their blood pressure measurements, as well as some other vital signs if they would like, either directly into the app. And I've listed one here on the slide called Heart Track that allows them to enter in this data. They can do that manually, or there are now some home blood pressure monitors that actually have Bluetooth capability that once you have that monitor and the app that are linked, you can actually, every time your blood pressure is measured, it will automatically transfer your readings into the app so that it can be looked at by a clinician if they're actually subscribed to a cloud-based portal that would then share that information. This is actually a really cool innovation because it was developed by one of the directors of my clinic who's at the University of Alberta. So something that's been spearheaded and developed, which I think has been a great innovation. Patients find it easy to use. And so when I'm looking at a patient profile, I can actually see what their blood pressure management has been like in the preceding week or couple weeks. If I then want to look back to what their blood pressure was prior to starting the medication or the change that we might have made at the last visit, I can compare two different time frames. And it has this neat functionality of what we call swipe averaging, where you can just trace your finger over a number of days or use your mouse and travel over a number of days, and it'll automatically calculate some blood pressure averages, which is so critical to how we make a lot of our clinical decisions. So this type of technology is available. I think it's an emerging field in medicine, but one we may see more of, especially as people want to have more accessible healthcare from their living room. So this is something that if you're interested in having a use of something like this in your practice, would be available to you to augment how you get data into your patient portal. Some considerations on maximizing efficiency. I was sort of thinking about this for this presentation and how we prepare patients for that virtual visit. And one thing that I wouldn't say we've necessarily done consistently in our clinic, but that could be really helpful, is when we set up these virtual visits, if we had some notifications that went to patients that just told them, you know, what the expected duration of the visit would be, what are some pieces of information that they should have readily available so that we can ask them about those things and they have that information at their fingertips. So just thinking about their blood pressure recordings, regardless of what type of mechanism they're using, have they been doing some of those recordings at least twice a day for the few days leading up to that visit, ideally a week, but we will take anything more than nothing. What are their medications, and do they have their pill bottles in front of them, or their blister packs, or their medications that they use routinely, and can they tell us what those names are and what the doses are so that we have that, as well as the name of the pharmacy that they're using in case we're going to have to be in touch with that pharmacy after their visit. In terms of the blood pressure readings, I mean, I'm going to show you one of the tools that Hypertension Canada has available on their website to assist with this. So we can either use these telemedicine platforms, or you could have fax or email of this information so that maybe in advance of them having the visit with you, you could review these things. One note is just to make sure that you have a secure email server if you're going to be using that, or letting patients know that the degree of secureness that exists within that platform. So with that, I'm just going to talk a little bit about blood pressure home monitor selection, as this is such a critical element in how we're going to help patients manage themselves and achieve the results we want them to achieve. And this just outlines the many advantages for the use of home blood pressure monitors. We can get more rapid confirmation of the diagnosis because we can get multiple readings within, you know, a series of days. The ability to, this has been shown to improve our ability to predict cardiovascular prognosis. So highly correlated between home measurements and outcomes, as long as we feel that you're doing that accurately and with an appropriate monitor. It also, interestingly, leads to improved blood pressure control, and potentially that's because people actually know what their blood pressure is and can be aiming for that target and partnering with us around how to achieve that most effectively, and then improving their adherence to drug therapy, as well as minimizing the white coat effect that can happen when we are doing blood pressures in an office-based setting. So this was an elegant little paper that was presented about how to check that a blood pressure monitor has been properly tested for accuracy. And it's interesting that there are a lot of monitors on the market that maybe have not been tested for accuracy. Fortunately, in Canada, we have Hypertension Canada, which has really spearheaded selecting a monitor, and they've created a recommended device listing. And there's a couple different check marks with a half heart that you can see on the slide there that indicates the protocol by which the monitor has been actually approved or recommended by Hypertension Canada. I'm actually going to share my screen to take you over to the actual website, because I think that would be really helpful for you to see. So here we have the Hypertension Canada website. Just one sec. Here we go. So you can see on here on the main page, if we're under the professional tab, when you come down here, you can see a recommended device listing. And if you hit that explore button, then you should be able to come onto this page, which has the recommendations for the blood pressure devices. And you can see here that we have not only the brand and the type of monitor. So in this particular case, this is an ambulatory blood pressure monitor. So we have them categorized by the type of blood pressure machine and the context of the setting. So this would be used in a clinical setting. And then it'll actually tell you what the cuff sizes are that are available. So as you come down here, we see all the ambulatory monitors. Then we see the clinic grade blood pressure devices. So if you're looking to have a clinical setting where you're looking for something robust enough for lots of measurement, you have some there. And then we get to the home blood pressure devices. And so again, you can see the brand, you can see how it's been rated by Hypertension Canada, and importantly, what size of cuff comes with the monitor so that you're using the appropriate cuff size for the patient that's going to be measuring their blood pressure. And last but certainly not least, when you come down to the bottom, they actually even rate and have some information on the kiosks that are found in pharmacies. So here's a little bit at the bottom around blood pressure measurement kiosks and how they've been rated. So really helpful when patients are frequently accessing this type of information. And then last but not least, I sort of mentioned earlier about using HeartTrack as a recommended mobile app, and you even have that here on the slide. And there's a quick start guide. So if you wanted a patient, or if patients were interested in using that, this quick start guide is a couple pages. It will tell you how to download and use information like that so that there can be transmission of your readings directly potentially into your phone. And then if you're with a clinician who uses the portal, that's also a possibility. Okay, so I'm going to go back to my presentation. Okay, so next is, well, what if you have a monitor that's not on the Hypertension Canada list? And so I've included a link here that links to a website that has some general registries. I apologize for the red box. It may not be quite as noticeable, but there's two registries here. One is called the Stride BP registry, and one is called the MetaVal. And these are registries of validated blood pressure monitors in all of the clinical contexts, and will give you maybe another larger list of monitors, especially if people have had monitors for a long time, or they've picked them up and they're not really even sure where they bought it. There may be a larger listing within each of these registries that I think can be useful to both patients and clinicians alike. So I've included the Stride registry here, and here's the URL on the upper right-hand corner of this slide. I'm going to take the liberty of sharing and showing you this website as well, because I think it shows and highlights how you can scroll a site like this. So if we look at the Stride registry, you will see here, you come onto a screen that has validated blood pressure monitors, and you can see the different contexts to which we may want to measure blood pressure. And you can actually just download a list of what's available. If you continue to scroll down the list, you can see that you'll then get into a device listing. So you can look at populations. Are you looking at an adult population, pregnancy, children, obese? What is the type of use? Is it for home use, for office use? There's a manufacturer if you're looking for a particular type of model and you're wanting to know if it's validated. There's then the measurement site. So are you doing this on the upper arm, on the wrist, the finger? And we're even seeing some cuffless devices now. I've not seen one of those myself. And then finally, the measurement method. So are we doing this as a automated oscillometric? Are we doing it as cuffless, etc.? So gives you lots of information as a way to access information about your monitor that may be useful for you. Okay. So then coming back to the presentation. So a couple tips on just proper BP measurement. If there's one thing that we want to have our patients doing with these machines, we want them to do it properly. You want to use a validated or endorsed machine. This little diagram on the right-hand side of the slide is produced by Hypertension Canada, and I think really gives you a visual of what that setup would look like. Your back is supported, you're seated, that your feet are flat on the ground, your legs are uncrossed, you're not talking, and importantly, you have a table that's sort of at heart level where your arm can be fully rested on that table, so in a relaxed state. And we do see on this particular avatar that there's a short sleeve shirt on. Certainly if you have a really thin shirt, you can probably put the cuff on over the shirt, but we ideally recommend that you do it on a bare arm if that's possible. I've highlighted, this resource is on the website URL here, and I'm going to show you that website again at the end of the presentation. There's a nice 10-minute blood pressure teaching video that's also in the resource section of how to measure blood pressure properly. And I think this is good for both clinicians and patients alike, and gives you a really, really practical information on why you should measure your blood pressure using this setup to make sure we have an appropriate measurement. And then if you are using, the good old fashioned paper, which there's nothing wrong with that, or paper on your computer, this is a way that you can record your blood pressure properly. And Hypertension Canada has created a home blood pressure log. In talking with Dr. Bell to prepare for this presentation, he can download this and actually send that through his secure portal to his patients, so he can, as a clinician, transmit this to them to use. And it really gives you, I've cut it off a little bit, but it gives you a 7-day reading or spaced chart to record day one morning, day one evening, and so on for 7 days sequentially, where you then can average all of the readings for days 2 to 7. So we eliminate that first day where we may see higher readings initially, and then average the following days. So we would usually typically have about 24 readings over a 6-day period that we could then average to have a look at somebody's level of blood pressure control. So just to end out the presentation, and before we get to the Q&A, I want to just highlight the Hypertension Canada website. And for those of you who have never really used this website, I think this would be useful for you to see. Just along the vertical toolbar at the top, you can see that there's a section for professionals and then a section for you as your patients, so hypertension and you. And just on I sort of showed you a little bit when I went to the device listing, but right on the main page under professionals is that device recommended device listing. So that's a really great handy bookmarked site that you can have if you're looking to direct patients to monitors that would be readily available in Canada. Likewise, if you go over to the hypertension in you, you're going to see some different icons that really speak to the patient. And so I'm going to show you the website there, just so that you can see it. So here you have the Hypertension Canada website. Sorry. Are you seeing my slide still? Just one sec. I think I'm still on my slide. Just one second. I will come back to. Okay. So I'm on the blood pressure devices page. I'm going to come back up to the hypertensioncanada.ca. So when we come to this main web page, and if I go into the Hypertension and You link at the top of the page, this is where you're going to see a few things directed towards patient. But one is this download patient resources in the lower left quadrant. And when I click that, I get into a bulleted list of patient resources. So the blood pressure log was one that I had just shown you. It has a little bit of information at the beginning about what your target should be. And then you get into the one pager that shows you the actual log. So that can be really helpful for patients as well if they want just a measurement postcard. So if you don't even want to purchase this postcard, but you want to have a look at what it looks like, I'm going to make it a little bit smaller here, then this is just some information that they could peruse on their own to see how to take blood pressure properly, and reinforces some of those appropriate methods that get you hopefully as accurate a measurement as possible. So with that, I'll come back to my presentation. And here we go. And just to close out, a couple resources that I wanted to show you. On the hypertension.ca website, there is a professional certification that's available for pharmacists, and it arms them with the knowledge to identify and manage patients with hypertension. It is a course, and you can get more details there, but it's a way to make yourself a little bit more hypertension management savvy if you're looking to develop some certification in that regard and work more fulsomely with patients who have high blood pressure. I wanted to highlight on the right hand of this slide a video-based virtual course on blood pressure measurement certification. This was a sort of a pan-international collaboration for some organizations, which included Hypertension Canada, to put together a little course on teaching both clinicians and patients on how to measure blood pressure properly. It's about a 12 to 13 minute video with a little quiz at the end that helps to affirm your blood pressure measurement technique. And so would recommend that if you're looking to, again, build your skill level and knowledge around blood pressure measurement. I've included the registries here more as and I see one of the icons has moved over, but in the slide deck you'll be able to see the full web address there. So if you're looking for registries outside of Hypertension Canada's for monitors that may not be listed there, then that's just another resource for you. And finally, we'd just like to thank our sponsor, Auto Control Medical, for their unrestricted financial support of this program. And with that, I'm going to turn it back over to Dr. Bell.
Well, thank you very much, Ann, for a terrific presentation, thorough, yet concise, pointed, practical, Awesome. Thank you very much. We got a whack of questions to get to and not a lot of time to manage them, but I'm going to take chair's prerogative and be the first to ask you a question. It's really unique hearing the perspective coming from Alberta. Here in Ontario, we're pretty backwards and we don't have pharmacists managing hypertension, which I am a very powerful advocate for. This should be a national project, considering the workforce of pharmacists out there and the challenge that we as clinicians, medical clinicians have seeing our patients on a regular basis to follow their blood pressure. So can you tell us a little bit more about this collaboration? When you see patients, do you always have to collaborate with other clinicians, or can you just manage them solely on your own? I also wonder about your collaboration with the outside physician that may also be looking after this patient. How do you share the information with that outside physician? And finally, tell me a little bit more about your scope of practice. I understand you can order lab tests, but what about EKGs, imaging, that sort of thing?
Yeah, no, great questions. I was really fortunate to get involved with a great group of physicians when I moved to Edmonton. And so just to speak about my practice, I would see patients typically collaboratively with the physicians I work with, but there are times where I will independently make a decision and then document back to the physicians. In the pre-pandemic days, we would work in a typical clinic-like setting. So I would be seeing a patient simultaneously while a physician was seeing a patient in the room next door. And then we would sort of collaborate or huddle outside the room to then finalize up a plan. Typically, the patients will see the physician in the model that I work in, so that if there's any questions that they have that are specifically geared towards medical concerns they have an opportunity to address that. But they'll spend the bulk of the visit with me to determine that plan. For new patients, obviously we involve that physician even more to set up any of the investigations that are needed. Follow-ups can be a little bit more, I spend the bulk of the time and have less time in that crossover. Certainly for phone call follow-ups where a question has emerged, I will answer those things and just report back and share into the electronic health record. So I would say we really adopt a collaborative approach, but there are some things where I can do them on my own. In terms of my scope of practice, you're right, we have probably the largest scope of practice of pharmacists in the world in Alberta. So I have what's called additional prescribing authorization. So I can write all the prescriptions and sign my name to them. And I can do that independent of the physician, albeit it's not a secret. We're a team approach. I can also order lab values. So I will order labs. In terms of diagnostic tests, I have done that and the system will let me do it, but I've sometimes we've received calls like, who is this person? Because the intent is that that test would be reviewed by the physician, because I'm not skilled in reading an ECG. Although I technically can order it, I really want it to be through the physician. Did I miss a part of that there?
No, you nailed it all. But I guess what I was getting at is, Hypertension Canada, as you're aware, offers a professional certification program. And I want to emphasize that, through this scope of practice and expanded scope of practice, that Alberta pharmacists should feel quite comfortable, I think, in managing hypertension without having a physician on site that you have the luxury or barrier of having to deal with.
Yeah, no, I would agree. And I think we've tried to encourage that. And I would say a lot of our graduates and our pharmacists in Alberta are feeling more and more comfortable to step into that space because they are seeing that happen. So stopping a medication if there's an adverse effect, adjusting drug doses for electrolyte derangements caused by an antihypertensive. These are things that I think we should empower pharmacists to do. And if they need to substitute a different drug, what do they think that should be? And then sending that collaborative note back, but managing the patient in the here and now, given that they're so accessible in their communities.
Right. Okay, let's get to some of the questions from our participants today. Naresh Karnik asks, what is automated BP measurements? I think that, I think we can start off by saying that I think that mercury sphygmomanometers are definitely very 90s, shall I say. Perhaps just a couple of words about the advantages, or what is automated BP?
Yeah, so automated is really that you can put a cuff, apply a cuff to a patient and then press a button and it will automatically inflate and deflate the cuff at an appropriate interval to give you a blood pressure reading. So I would say our practice is entirely automated. The last time I've actually used that cuff that's attached to the wall in a clinic room is a long time ago. So it's really that automated process. And what we've learned is that multiple readings tend to get you a more accurate blood pressure that's true, what we would consider true, or regress to the mean of what the actual blood pressure is. So it's just the process of having it automated with a button, so you don't have to do manual inflation and deflation of the cuff.
Yeah, if there's one thing that I emphasize when I'm talking to my colleagues in primary care is get rid of that mercury device on your wall. The recommended utilization is now with automated office blood pressure or automated home blood pressure, even better than office, as you're indicating. We have some questions related to cost. It's sad that there is a barrier that for patients who want to obtain a blood pressure machine, but there's also another question regarding the cost of the HeartTrack app. And are these available broadly to patients? And what's the story on that?
Yeah, so HeartTrack is actually a free app, and as you know, and I've talked to the developers, and they will make the cloud-based monitoring free as well. So if you're looking for more information on that, if you go to your Google search bar and just type in A&D HeartTrack, you will come up to I think it's usually your first hit that will give you some information about how you would do that. And I just nicely saw that the Hypertension Canada website has actually put some patient-focused instructions there on how the app can be downloaded for free from Google Play or the Apple App Store, and then patients can start using it. So I think that's the simplest way, because you're going to need to that's going to take a little bit longer to give you some of the details, but there's absolutely information out there that would help you to implement this into your practice. And I would say it's been really, really great for our practice.
Yeah, it really is a tremendous tool if you can get people to start using it. The nice thing about it is it averages blood pressure for you. Try to get your patients to do home blood pressure and then average it. Sadly, a lot of my patients have a challenge with that one. We have a question from my colleague at Lung Association, Lana Brio, who's asking, would you be able to find control, please? How consistent should the target BP be for hypertension to be considered under control? Thank you. So, maybe just, I can start this off and just talk a little bit about blood pressure targets and thresholds. And, it's a bit of a complex topic, but I think that we have to understand that for the broad majority of patients, we like to target blood pressure to be below 135/85 when measured at home with an automated device. Patients with diabetes, we need to lower that down to 130/80. And then patients who are at high risk of cardiovascular disease for a whack of reasons, we want to target it at 120 systolic or lower. Would you like to add anything to that?
Yeah, I would just say in terms of the degree of control, we consider you pretty well controlled when you're below those thresholds about 80% of the time. I mean, to say 100% of the time you're going to be below that is probably unrealistic. And we have patients that will say, geez, on this day, my blood pressure went sky high, but now it's normalized again. What's going on? Should I do anything differently? And I would say, trends are really, really important over time. We know that blood pressure medications reduce blood pressure, but they don't always reduce the variability of how your blood pressure can change across the day and in relation to the activities that you're doing. So I think we generally try to have the in control range be at least sort of 80% of the time if we can, and try to mitigate that you feel really crappy if your blood pressure is too low. So trying to hit that sweet spot of sort of keeps you in control most of the time. All right. Is that consistent with your practice, Dr. Bell?
Yes, it is very much so. All of my patients with diabetes, all of my patients with hypertension get the Hypertension Canada material that you outlined, particularly that 2-pager that on the first page outlines proper blood pressure measurement technique. It emphasizes the point that you made about back supported, feet on the ground, no recent smoking or eating, arm at heart level, etc. But it also has that page. Every single one of my patients gets a PDF of that form for them to assist me when I'm having the blood pressure discussions with them. And what I aim for is I don't like to tell my patients 80% or 20%. I like to tell them, are most of your readings at the target that I've written on that form for you? Most of them. And then I'll get them to, perhaps show me or email me their form and I'll have a look at it. But yes, very much so. And I think that it's really incumbent upon all of us to start using home blood pressure much more. As you pointed out, and it is more predictive of future cardiovascular events. It allows us to identify white coat hypertension. It allows us to identify masked hypertension. And now during the pandemic, it allows us to monitor our patient's blood pressure, something that otherwise we just, are very, very challenged to do.
Totally. And just like a little tip, I would rather a patient does 2 readings in the morning and 2 readings sometime at night, sort of 8 to 12 hours later, and do that intensively for 3 or 4 days, ideally 7, and then put their monitor away, versus the patient who does a reading sporadically, like twice a week over the last 2 months. I feel I can get a better sense of what their blood pressure is doing to have a short number of higher numbers of readings than having sporadic readings done all the time. So I sort of say to my patients, get your monitor out, have it visible, use it frequently. And I think the majority is twice a day is what's needed. I don't think we have data that says you have to do it more than that. But do it twice a day and 2 readings each time, write those down, and then bring that in and we'll talk about that. Then you can put your monitor away for a period of time and you don't have to feel that it's sort of something that you always feel guilty if you're not doing it. I don't think you need to feel that way.
I think that's exactly right. Some patients get totally obsessive with the thing and they're measuring it 10, 12 times a day, same thing with diabetes monitors. I think that is an important point to make to our patients. Sure. Peter Tion asks, are cuff monitors, arm cuff monitors favored over wrist cuff monitors? We have recently made some very specific recommendations about this on our Hypertension Canada guidelines. Do you want to address them? I'll let you start, Ann.
Well, I will tell you, I mean, I've been doing this for about 14 years and I felt like wrist cuff was sort of a dirty word at the beginning of this journey in hypertension. And I would say it's now, there are a few that are actually validated, and we actually have some patients, specifically if they're in some of the obesity categories where we just can't get an appropriately fitting upper arm cuff. So I would rather use a wrist cuff that fits and can get a measurement versus an ill-fitting or improperly fitting upper arm cuff. I would say though, if you look at the data, the majority of tested and machines utilized for clinical research have been in upper cuff monitors, so upper arm cuff monitors. So that is, what we would firstly recommend, but then there are a few wrist monitors that are now endorsed by Hypertension Canada and with the Stride Registry. So there are options out there. And if that's a simpler way and is more encouraging that you'll use the machine that way, then I think you may be able to get a valid reading using a wrist cuff. I find it intriguing that there's new technology, cuffless technology. So I think this is going to be something that will continue to evolve in our lifetime as to what instruments are used and how accurate they are. At this time, I think the cuffless technology is really intriguing, but we just don't have the accuracy data to make that sort of part of routine clinical practice.
Yeah, not ready for prime time quite yet, but I do look forward to the day.
Right.
The other comment that I will make on that is that Hypertension Canada recommends in our current guidelines that upper arm cuffs be used in patients, except in those in whom you can't get one big enough to get around. Right. And there are certainly patients out there that fit that in my practice, and I think in most of our practices. And that's where wrist cuff monitors that have now been validated are extremely useful to monitor hypertension, particularly in our morbidly obese patients. We have a question from, I presume, a patient, Rubini Siva, who asks, how do I know if my blood pressure machine is in good condition? How often should I change my machine? Great question.
It is. I was fortunate to be part of a study where we actually looked at comparing home monitors. People brought their own in and we compared it to a gold manual standard, which is the mercury sphygmomanometer. So we actually used that, and we would do a series of measurements between the home monitor and the mercury monitor. So we were actually changing cuffs quite frequently to do a series of measurements on both devices. And interestingly, just because your machine's old doesn't mean it doesn't work. Just because it's new doesn't necessarily mean it's working or accurate. So I generally, and the thing is with these electronic machines, they're either accurate or they're not, but you can't open them up and recalibrate them. So you're really trying to say, do you think it falls within the range of what you think your blood pressure is? In our clinic, we would have patients bring their machine in and we would test it against ours. Now that's assuming that ours is also accurate, but we would do that and sometimes even do a manual measurement as a way of triangulating to see if we thought that the cuff was concordant with other measurements. In a gold standard way, you would have a 24-hour blood pressure monitor done and then be using your own monitor, but that's just not practical or feasible for 99.9% of the people. So I think to answer your question, I think your machine is probably in good condition if you think it's generally been concordant with other measurements that you're getting, and it doesn't seem like it's reading something completely different from when you're in other healthcare settings or using other monitors. It's really the only gauge that you ultimately have. And I don't think you automatically need to change your machine just because it's a certain age old.
Right. I think that's exactly right. It's not a bad idea to do a visual inspection of the thing. If it's falling apart, if it's been frayed, if the dog's been eating the cuff, you might want to, if it's leaking, any of those things. Boy, we're running out of time. It's a shame, but I love this question. It's from an anonymous participant who asks, for pharmacists just starting to make change in their practice, what recommendations would you suggest as first steps?
Oh gosh, that's a good question. I think becoming knowledgeable about hypertension, so reading up the guidelines and making sure that you feel comfortable with, I think, the therapeutics. I think I would then shift some of my thought process to my patient assessment process. And I talked a little bit about that focused interview, but what are the things that you think are really going to help you to make clinical decisions? And I think I would focus in on that. I think my last tip would be is through any of your professional associations, are there ways you can connect yourself with individuals like myself or others that are doing this in primary care spaces that can just help you to think through some of your workflow and ways that you could actually ultimately help patients. And I really think pharmacists are well positioned to really help Canadians by getting involved in this space. So I'd make those three initial recommendations.
Well, I'll tell you what, I could not agree with you more. I wish we had time for more Q&A. Unfortunately, the clock on the wall tells me that we are already a minute over time. I want to close today's presentation by first of all thanking you and for, as I said, a terrific presentation. I want to thank all of our participants for coming out today, demonstrating their interest in lifelong learning as a healthcare professional or as a patient. I would also like to thank our sponsor, A&D Medical, for allowing us to create this completely independent of any intervention from them and making this all possible. And finally, I want to emphasize to all of you to consider registering for our annual Congress at hypertensioncanada.ca. It's going to be a 2-day event, May 13th and 14th of 2021. I think you will find the time extremely well spent, whether you are a pharmacist, a physician, or any other healthcare professional with an interest in hypertension. And with that, I will thank you once again, Ann, for your presentation and wish you all a good afternoon. Bye-bye now.